Welcome to the CBT Dive, a vodcast that goes into the lives of real people with real struggles. Each episode welcomes a new guest who wants to explore a challenging situation using the most common cognitive behavioral therapy tool, the thought record. Your host, Raheem Thawa, is a social worker and psychotherapist based in Toronto and well known for his work in LGBTQ communities. He's created the CBT Dive to demystify what therapy can look like and share intervention skills for wellness. We hope that each episode helps you along on your own journey for insight and self-compassion.
Hello, Dr. Trevor Hart. How are you today?
I'm doing well. How are you, Raheem?
I am living the dream. It's so good to see you. Somebody from Toronto.
Yep, and I'm excited about your travels across the world.
Yeah, and I brought the CBT Dive with me to Johannesburg. Before we get into it, you know that I have a lot of questions for you. I'm just going to share with our listeners a bit about you. Dr. Hart received his doctorate in clinical psychology from Temple University. After graduate school, he completed a postdoctoral fellowship at Emory University's School of Medicine, through which he received training at the U.S. Center for Disease Control and Prevention. He has received several awards for his advancements to research and clinical work, including induction as a fellow of the Canadian Psychological Association and as a fellow of the Association of Behavioral and Cognitive Therapies. Dr. Trevor Hart is the director of the HIV Prevention Lab. He holds a research chair in gay and bisexual men's health from the Ontario HIV/AIDS Treatment Network. Dr. Hart is currently conducting multiple studies, including a test of new gay and queer-friendly therapies for social anxiety for HIV-negative gay and bisexual men, and a study examining how biomedical HIV prevention, such as the use of pre-exposure prophylaxis or PrEP, is changing attitudes and sexual health for gay and bisexual queer men across 3 cities in Canada. He also has a private practice focusing on CBT and other evidence-based therapies related to sexual minority people in Ontario. Dr. Trevor Hart, did I capture all of that okay?
Looks good to me.
So I'd love to just tell the viewers, I met Dr. Hart when I was first working like pre-MSW, when I was working at the Alliance for South Asian AIDS Prevention. And that was in 2009. So we're talking over a decade ago. And Trevor has been kind enough and supportive enough of my career trajectory to invite me to be on all kinds of advisory committees. And we've spoken together at conferences, and he's always been very respectful and kind of supported me along in my career. So I'm excited to have him here. So, Trevor, I'd love for you to tell me a bit about CBT. What do you like about it or love about it? And in the therapy you do, what kinds of CBT tools do you tend to gravitate towards?
One of the things I wasn't originally trained in my undergrad to do CBT. I was trained in a program that really didn't talk much about it. And so I was a bit surprised about all this CBT stuff. And I had received some negative messages about it too. Oh, it's not real therapy. It's a symptom management. It's not going to help you with anything important. It's just, a surface level. And then I found out that when doing CBT, I had patients that were getting better. I had patients that were grateful. We were making real life changes. I remember being at a practicum where I was helping somebody with one supervisor and then switched supervisors. And then the supervisor was like, why aren't you doing this, that, and the other? Your patient's not really getting better. And I was like, yeah, they're not. And I'm like feeling really upset about it because I want to really help them. They're really suffering from a lot of anxiety and depression. And they were like, have you considered using a CBT approach? And so what I did is I integrated that CBT into the approach that I was already using. And then that patient got a lot better, and then they were doing a
Right.
lot better. And one of their comments to me toward the end was, I've really appreciated all the work that you've done to help me to change my life. But if you don't mind me saying, why don't we start this earlier? Because I felt like we were just kind of like just talking about stuff, but not making any real changes in my life before. And I was like, ugh. So
Yeah.
that was one of my first experiences where I was like, maybe the CBT stuff is actually pretty good. And maybe that kind of straw man that's painted, you know, about like, oh, it's surface level is kind of not really accurate.
Right.
You know, I really think that there is an increasing awareness about the benefits of CBT, and that it's realistic. It's realistic and it's effective, and it can help people across a variety of problems: anxiety, depression, eating disorders, health behaviors,
Yeah.
quitting smoking, managing overeating. Like it can be really
So many
helpful.
things.
That's why I like it.
Yeah. You know, when you said you started seeing people get better, and at the end of sessions or at the end of your time with clients, they were thanking you. I've had a similar experience, and I find it's part of it is, you know, people really feel like something concrete is getting done and something tangible. Um, and, you know, if you're talking, that can be helpful, but people don't leave with something to concrete to reflect on, right? And so something like a thought record, I find is really great. Like I've heard people like they'll take their thought record and then put it on their fridge, or they'll reflect on it from time to time. Are there specific CBT tools that you like or use? And do you do them in a written format, or do you kind of do talk therapy in a way that's informed by CBT thinking?
Yeah, I tend to do work that involves both talking and writing it out. I
Mm,
find that it's hard to remember when people say, "Oh, I did think about it." And like, tell me
yeah.
about what you thought. It's usually kind of very ad hoc, and it's like it can be very surface level, where it's like, I thought to myself, I don't know, imagine I was giving a presentation on
Yeah.
a video podcast to, you know,
Mm.
an important member of our community, and you want to do a good job. Imagine I was doing a thought record. Oh, and I thought, well, you know, I guess I'm going to flub this up. I'm not going to sound competent. And then I do it in my head. I might end up with something like, you can do it. Like just something that like you might hear from your friends, right? But
Right,
if you do
right.
a full thought record, I think you can go a little bit deeper than cheerleading. And I think cheerleading is
Mm.
good, by the way, but I think we can do even more than that as therapists.
Yeah, you
But I want to
know,
answer your question about tools too. Do you want me to
go ahead.
hold on for a sec?
Um, no, I just wanted to say when you said you can go deeper beyond the cheerleading, I think I just want to point out to people that, you know, the process of coming up with the negative automatic thoughts and then distilling them a bit has so much depth to it. And so it really counters that idea that it's surface level, because when you're digging what's underneath the automatic thought, it does go deep. But please go ahead. Tell me about your favorite tools. What do you like? What do you hate?
I don't think I hate too much, but I tend to use the tools that are used in CBT. CBT's got a lot of tools. There's psychoeducation, which is understanding your psychology, your psychological strengths, and your challenges. I think that's a good first step, is just to gain some insight as to what do we know. And CBT therapists are not afraid to say, hey, what do we know from the research literature? Like what things have we learned as far as what causes a certain problem or what makes it maintained, but then also making it come to life by talking about, hey, to what extent is that true for you? What's going on in your life, or how
Yeah,
much does that jive with your experience?
right.
So that's one tool. Another tool is cognitive restructuring, which is helping to change the way that we think so that our thinking is more rational, helpful, or aligned with our values. And I'd say that's
Mm,
a key component of the thinking part of CBT, changing the way we think so that we
yeah.
can think in ways that make us feel better. There's
Mhm.
also behavioral experiments or exposures, facing difficult and anxiety provoking situations so we can do what we want to do in life. There's relaxation exercises that we can use when we're feeling stressed or just having new ways to reduce our muscle tension and our anxiety. And then there's mindfulness exercises like learning to live in the moment and to understand our thoughts and feelings as fleeting experiences like anything else that we can experience, and not being overwhelmed by our own thoughts. So I'd say all of
Yeah.
those things would be things that I think are great tools, and they've got great evidence for them.
Great. I'm so glad you talked about both psychoeducation and mindfulness, because people sometimes will start therapy, in my experience, and they'll say, I've received this diagnostic label, right? And I might say, do you know what that means? Or what does that mean to you? And sometimes they'll say, it wasn't really explained to me. I've just had it forever. So a bit of psychoeducation about like, when is this diagnosis usually given? What does it tend to mean? What are the common symptoms? How does it look in different people? How does it manifest in your life? Might it prevent you from doing, or why might something be difficult? Goes a really long way. I'm glad you mentioned mindfulness, because it's not always talked about as being part of the package of CBT. But for a lot of folks, we can only access our rational mind or our alternative ways of thinking once we're grounded. And so pairing that, sometimes students I supervise will say, when do I use this mindfulness business? And I'm like, well, it could even be a good way to, it could be something useful to do before you do a thought record or before you get deep into the thoughts, right? Help ground somebody and help reduce their level of anxiety. Um, I personally find behavioral experiments very challenging to do with my clients. Um, Dr. Hart, do you have trouble with those, or any of the tools? Or is there a tool that you find clients have a lot of trouble with?
I think it's pretty random to me what folks will have more trouble with or less. I think some
Mm,
folks have trouble getting their mind around cognitive restructuring, either
yeah,
because it's a little tough, like for them to kind of figure out their own thoughts, are
yeah.
not aware of their thoughts, or they find it a little bit. For some folks, it can be a little intellectually challenging, where it's like, what is it? I have to what, and then I have to do what? Like, there's a bunch of steps.
Mm,
And for other folks, they're so intellectual that they get wrapped up in their own thoughts, and I have to like take them back down to earth, right, and be like, let's talk about which thoughts are helpful, as opposed to having a discussion about what thought is more logical and what thought is less logical, and what
right.
does logic mean. And like you can
Mm,
go there if you're not aware that your goal is really to help the person and not to have a
mhm,
really interesting conversation.
yeah.
For behavioral stuff, people are avoidant. People don't come to see you for CBT usually because they're feeling confident in their abilities to do whatever they want to do, right? So they do this thing called avoidance, where they avoid doing the things that they want to do. They wanted to ask somebody out for sex, or for a date, or to hang out, but they avoided it. They wanted to tell their boss that they had some good ideas that could change the way that they do things at work, but they avoided it. They wanted to speak up at a meeting, but they avoided it. And
Mm,
so all these behavioral experiments, those are all things about going to do the things you want to do, testing out your thoughts. So if you have a thought, no one cares about what I have to say at work, and then
mm,
that thought leads you to not acting, you can use a behavioral experiment to say, hey, how about I intentionally raise my hand at that Zoom meeting or in-person meeting, and I articulate my point? And will people just say nothing, or will people say that's a good point? Or
mm.
there's opportunities for people to learn about how they can engage with the things that they want to do, so they can feel strong and empowered.
Okay, I love that example, and you're making me want to try behavioral experiments again, with clients. I really like that you point out that it's not supposed to be easy. People are coming to work on things that they're avoiding or having a hard time with. I find that like that gives me helps me access my own empathy in working with clients, because I think it can sometimes, when you're lacking motivation or you're afraid of judgment, I think it's stressful for the client to put themselves in a difficult position, and sometimes it's stressful for the therapist. And as I'm thinking about it, I'm thinking, oh, I wonder if it's my anxiety that gets in the way. What if my client tries something in a behavioral experiment and it doesn't go their way? And so it's like I'm catching their anxiety. It's contagious. So I have to work on that. Trevor, what is it about CBT that makes it so popular? It seems to be a common go-to for a lot of people and organizations. I've had students I supervise that say, teach me CBT. And I'll say, okay, I'm happy to. What interests you about it? And they'll say, every job description I've looked at says I need to know how to do this. So maybe you can shed some light on why it's so widespread and so popular, particularly in the nonprofit sector.
Well, let me tell you, that was not the case when you and I first met. Whether it's your first memory of me or vice versa, that was not the case. I think things have changed in the last 10 years, and it's a part of an ongoing change. And the push is really towards just a pragmatic focus, just like we want people to get better. We know that there's a variety of therapies available. CBT is not the only therapy that you could use, but we also know that CBT has the strong evidence base for it, saying, you know what, it's going to help. It's going to help you with your client or patient. By the way, I use those terms interchangeably. The
That's
humans
fine, yeah.
that we're trying to help.
Yes.
So that it works basically. So at first, I think there was even some resistance to CBT, like, oh boy, it's surface level, because the psychodynamic people thought that they were doing very deep work, or the more humanistic people didn't like that it was directive, because it meant that you were disempowering the person. And so there was a lot of resistance, actually, and there still is quite a bit of resistance in the field against CBT. But I have to say, I think what people like at community-based organizations is they like their people getting better quickly, and that they care less about what theory and how much the therapist likes the theory and is sold by the theory. What they care about is not theory. What they care about is, can we show the government that we've helped 300 people get better in the past year, and we can show, actually show that it was not just they said they really liked it and they learned a lot, but they said, I'm feeling better and now I'm able to function. I'm able to get off of ODSP if they want to do so. It's touch and go as to whether that's even a good idea in Ontario, because of our disability framework is very challenging to work with. I'm able to get to work. I'm able to enjoy my love life and my sex life. And so I think I think it's really just the many of the organizations that we work with, they don't care about our theories. What they want to know is what gets people better. And by the way, I want to tell you, I'm not in the CBT camp. I'm not in that camp. I'm not a part of, I don't follow, I'm not a Beckian or a Ellisian. We don't have that in the way that I was trained. What we have is evidence-based. And I will tell you that if we find that something else works better than CBT, and we can show that it works better than CBT, I'm going to be pissed. But you know why I'll be pissed? I'll be pissed because I'm old, and that means I have to learn new stuff. That is why, not because I think CBT is the way to go. I just think right now it's got the strongest evidence base, and I want to help my clients the best I can.
Yeah, no, that makes a lot of sense. And I think you've known that, I've been of two minds about CBT. I think it wasn't too many years ago that I was quite critical of it. Do you remember that?
I do. And I remember us having a conversation. I was like, what about CBT? And you were just like, meh. And I was like, okay. I'm like, I don't know what to say, because so much of it, when we're trying to fellow therapists, it's about your readiness to accept messages and your readiness. And I was like, I don't know, it's my place to tell a fellow therapist what to do.
But I've come some
I was
way.
surprised you came to me with the CBT dive. I was like, okay.
Yes. Well,
I was not expecting it.
I think we should pause there for a moment and just delve into that if we can. I asked you to come on the show for that very reason, I think, because I've been at a conference where you've talked about CBT and I've been like, I don't think this is a great idea. I don't think this is great for clients. I've had strong opinions like that. And I continue to be of two minds about CBT, you know, when I'm like, I'm not sure it works for everybody. But, you know, there's a few things that I've realized. One is that CBT can be adapted to work for different people. And two, it's easy to criticize something when you are struggling with using it yourself. And so that's an admission that I, you know, didn't fully know how I could use these tools. And when I started to supervise students, I found by the time I started to supervise students, I had taken two like intense trainings in CBT, and they came in with a lot of critiques about it. And they would say, you know, it's not client-centered, it's not this, it's not that, it's not anti-oppressive. And I would say, well, I don't know that that's true. I think any therapeutic modality can be done badly, right? You could say, you know, psychodynamic free association is client-centered because the client gets to do a lot of the talking. You could say CBT is client-centered because the client picks the goal. You could say both of those are bad for somebody through some other rationale. So I said to my students, and I've come to learn this very much, you can critique something once you've learned how to do it and you've attempted it, right? You really need to try it with clients and see how it can fit into your practice. And I started the CBT dive because I thought I really want students of therapy, people who are training in CBT, other professionals, and folks who've, you know, gone through some therapy to just come to the podcast and see how we work through things in a very linear way. I think that's one of my favorite things, is how you can really isolate a problem and work through it in a linear way. So it feels like I've come to a point in my career where I'm appreciating a lot of the work you've done for so many years, Trevor. So I just want to say thank you for that.
I'm honored, Raheem. You're been such a leader in the fields that it's, you know, I knew you when you were kind of at the earlier stages of your career, and then you're just, I see you as a, you know, at the top of your game and just a real contributor to our community, someone whose voice is so valued and so appreciated. And so I'm glad I could contribute in some way. I mean, I think we're all learning from each other in the community, both the therapy community and also kind of the sexual and gender minority community. I think, and when we listen, we can also listen to critiques, but also hear where the critiques are coming from. Then we can improve our work, and which is part of what I'm trying to do, is improve what CBT does.
And having said that, so we both do a lot of work with LGBTQ communities or sexual and gender minorities. And from what I understand, a lot of your research and some of the practices you've developed or drawn on are about using CBT with LGBTQ communities. Can you tell me a bit about what that work has entailed and why is there even a need to adapt interventions to make them, you know, queer and trans specific or queer and trans aware or queer and trans competent? You can see that I'm not even sure what the language is, but there's a kind of adaptation that people talk about. Tell us a bit about it.
I mean, CBT, while it's really effective, it hasn't really been tested in the context of the things that many of us would experience who are members of sexual and gender minority communities, the LGBTQ2I and all the other identities that I haven't listed. So it doesn't CBT as done by cisgender straight people probably isn't going to take a look at societal homophobia, transphobia, heteronormativity, cisnormativity. And these are all things that we live in as sexual and gender minority people. Like, this is our context, whether we wanted it to be or not. And so what ends up happening is we experience a lot of extra stresses compared to people that might be a cisgender or heterosexual person. Everyone has stresses in their lives. Everybody has potentially financial stresses or family stresses or work stresses or other relationship stresses or social problems. But when you're a queer or trans or other sexual or gender minority person, you also have to deal with being treated in really derogatory ways as kids and as adults. Fear of being rejected for who you are, literally, like, should I tell this person? Should I not tell this person? Do they know? Are they going to treat me poorly because I exist? Or will they not treat me poorly because I exist? Do I try to hide whether I exist? Dealing with heteronormative and cisnormative comments from our families. Like, your own family of origin that might have been a place of support might actually also be a place of great oppression and concerns about where it's safe to be out. So there's I think there's a profound need for interventions that can be evidence-based, but explicitly anti-oppressive.
Yeah. So what does an affirmative CBT practice look like? And how does it differ from standard psychotherapy? How does somebody know they're being like LGBT affirming in their practice?
It's easier said than done, but it is also easily done. It just needs some thought. The affirmative interventions, they're gonna talk about the things that people normally talk about. So let's say if you've got somebody who's coming to work with you because they're having panic attacks, you might still help that person with their panic attacks. If they're depressed, you're still gonna help that person with depression. But you'd also can talk about stresses that we experience in the community, and sometimes those are called those minority stressors. So the stressors of being a part of a minoritized group, and we've talked about specifically kind of heteronormative and cisnormative kind of stressors, but this could be true for all forms of oppression, whether it's racist stressors or sexist stressors or classist stressors or anti-immigration stressors or anti-religion based stressors. So things that basically make you feel other than for doing nothing wrong whatsoever, just existing as a person that has your identities. And so these affirmative interventions, they'll talk about oppressive forces, and for SGM people, by helping SGM people, sexual and gender minority people, find ways to live their lives. Like, for example, our sexual confidence CBT program that we're testing out at Ryerson goes beyond typical CBT for addressing social anxiety disorders. So usually social anxiety disorder, CBT, you would talk about how you think about yourselves, face anxiety provoking situations like asking somebody out for a date or to hang out or going to a party, speaking up at a meeting. And all of this is great. This is great, but standard CBT therapists won't think about asking about, hey, you know what, here's another stressful situation. How about what do you do when you hear homophobic comments on the street? What do you do, what about a social anxiety situation called, I would like to hold hands with my partner who does not appear to be of the other gender, right? So, you know, like a heterosexual relationship. What do I do when I'm holding hands with my gender diverse or trans or same-sex partner? And they won't talk about gay sex. They won't talk about trans sex. They won't talk, oh my goodness, we have sex too, because it's like very uncomfortable to talk about sex. Like that's inappropriate. And but sex is an interpersonal situation where people kind of need to be assertive if they want to be able to give consent. So in the standard CBT, they wouldn't talk about any of this stuff, but in our sexual confidence CBT program, we talk a lot about it. So it's still
Yeah.
CBT, but it talks about the stresses that we experience in the community.
Well, this is the first I'm hearing of the sexual confidence CBT, and it sounds really fascinating. So perhaps you could share a link so listeners, I'll put it in the show notes and listeners can check it out. It sounds really interesting. So what I'm getting from you about queer and trans affirming or SGM affirming CBT is that one, it really takes into account like systemic issues people face, like kinds of discrimination, and validates that. So we're not trying to change a thought around, you know, I experience homophobia, and you're trying to convert that into a positive. That's not what we're doing. We're affirming people's difficult experiences in the world. And the other part of that is, as this as the affirming CBT therapist, you're going to places, topics, issues in somebody's life that have to do with the subculture they live in. So things to do with sex and sexuality, the interpersonal experience of being with somebody else, dealing with things like maybe internalized stigma or homophobia, that kind of thing. That sounds really fascinating. I'm also thinking, you know, what do you say to people who might say that CBT is too short term, or perhaps too surface level to deal with things like oppression, which is essentially what you're talking about, right? When you talk about discrimination people face, how do you respond to that?
Well, I mean, the first way is by saying, well, but we are doing anti-oppressive CBT. So gosh,
Right.
I think it could happen. I not only do I think it could happen, we're doing it, and we're anecdotally we're seeing some really good outcomes, and we're really happy about the improvements that some of our participants have been having. You know, CBT can be really short term, but it's not always. I mean, there are very effective programs that you could treat insomnia in only 2 to 4 sessions. That's really
Wow.
cool. Um, and although those short-term therapies are amazing, CBT can also be used to help people to process and move through past traumatic experiences.
Mm,
That doesn't sound surface level. To deal with social isolation, to deal with feeling unlovable, feeling like
mm,
unworthy as a person, feeling incompetent, feeling like that you're less of a person because you're a
mhm.
sexual or gender minority person, or because of your experiences as a racialized or indigenous person. Like, I don't consider any of that stuff to be surface level. I consider that stuff to be, in my opinion, very deep. And CBT doesn't need to be short term in order to be CBT. I've seen some folks for as short as 2 sessions, but I've seen some other folks for longer than 2 years, depending on
Yeah,
their needs. You know, my
exactly.
goal, what's different in CBT versus some other therapies, not all therapies, but some other therapies, is that the CBT therapist always has a goal to help that person to become independent and to feel like a whole person without needing the therapist. That the goal
Mm,
is to get it's a learning model in a way where you might learn some new skills, but eventually you don't need to, because you know as much as the therapist does, and you're
mm,
using those skills. You're not just knowledgeable in your head, but you're using those skills to strengthen yourself and to empower yourself on
yeah,
the inside. And
right.
so CBT does lean on the side of shorter term therapies, but what shorter term means for person A is going to be really different than person B.
Yeah, I really appreciate that. And you know, when you first were talking about, you were listing off some core beliefs, right? Like I'm unworthy, I'm unlovable. I think CBT's done a really good job of distilling a lot of common core beliefs. And I think when people look at those at a first glance, I think that's what makes it seem like it might be simplistic or surface level. But actually, I think this is where the psychoeducation comes in, particularly around trauma, right? Like when we look at having difficult experiences in the world, those shift the ways we see ourselves and the world. They shift how we see the past, present, and future, right? And it's in that context that we talk about core beliefs. So it absolutely can be trauma informed or trauma focused. Thank you for helping me clarify that. That is something I've also wanted people to hear and to acknowledge. Trevor, one of the last questions I have for you, where can people learn to be more affirming of sexual and gender minorities in their approach to CBT? Is there something they can read? Are there trainings, I don't know, you provide? Where can people learn more about this?
Well, the field could be a lot bigger than it is, but for the people who are listening, if you're listening, we've got something for you. So first of all, there is a book called The Handbook of Evidence-Based Mental Health Practice with Sexual and Gender Minorities by John Pachankis and Stephen Safran, who are the editors. And it kind of reviews the literature, but also gives some examples of like, okay, here's how you do this thing. Here's how you do that thing. And so these folks, the editors are folks that are all about affirming an affirmative practice in CBT with a focus in on sexual and gender minority people. I'd also say that like in the age of Google Scholar, you can actually, a lot of people don't know about it. They're like, what? You mean I can look at all of the articles? You can look at a lot of scientific articles for free just by going to Google Scholar, and maybe there are other free resources as well that are of other companies. But I happen to use it frequently, and sometimes a lot of the stuff is free. And there are journals like Cognitive and Behavioral Practice where it's journals that have articles in it, but they're written for us as clinicians, as therapists, as counselors. So it's like, okay, here's the problem. Here, let me walk you through it. Let me tell you how we address this problem. Here's how you can do it too. So there are journals like that as well. And we do some stuff at our gay counseling training hub. So we have something called, again, Gay Counseling Training Hub. I can send you the link for that as well. And what we do is we listen to the needs of the community, and people tell us like, I want a training on X, or a community organization wants to get a training on affirmative CBT, or they want to get training on, can you just give us some basics of working with LGBTQ2I people? Yeah. Great. Or you want to learn how to do motivational interviewing, which is another kind of evidence-based counseling. And you want to know how to do that to help your clients to make important changes in their lives, like kind of changes, let's say, in their health behaviors or other aspects of their life. We offer all of that, and it's specifically focused on gay, bi, queer men. But if you are seeking a training that's kind of more broad for sexual and gender minority folks, we're still into it. So we're not exclusivist. We're just funded to do this work by our funder with gay, bi, queer men. But yeah, we'd be glad to provide that training, and that's a big part of where the field needs to go, is to training folks and helping folks who want to help others.
Great. Dr. Trevor Hart, thank you so much for being a guest on this show. I'm really glad to have had you. And I look forward to, running into at a conference again and talking shop, and maybe we will co-present someday on CBT in sexual and gender minority communities. Thanks for being here.
Thanks, Raheem. It's always a pleasure to chat with you.
Thanks for tuning in to the CBT Dive. Don't miss an episode. Subscribe to our YouTube channel at the.politicized.practitioner. You can also listen on the go, wherever you get your podcasts. To follow Raheem on social media, check out ladyativan.com. See you soon.